Ladies and gentlemen, it's a great honor to lecture on neuromodulation in neurourology. In this way, I'd like to thank you, Julian, for this invitation. It was a great time that we had together as you were an ICS observer at the Baltrist University Hospital in my department. And I'm looking forward very much, Julian, once to visit you in person in Colombia, but also that you're once back to Switzerland, to Zurich. My conflict of interests are that I'm a full-time neurourologist and that I'm the INUS president. I'd like at this point already to thank my team. Ladies and gentlemen, it's a great honor to work with such a team. All is a teamwork. Without a team, it is not possible to be a completely independent academic department of neurourology. Many thanks to my excellent team members. Neurourology is very simple. First, you have to protect the upper urinary tract. Here, the Mickey Mouse bladder. And then, second, you have to improve quality of life of your patients. It means no diapers, no urinary incontinence. Protect the upper urinary tract, improve quality of life. And all what it is relevant in neurourology is summarized into this review published several years ago together with Jalish Paniker and with Claire Fowler. Look into this cover of the Lancet Neurology. Here it is summarized, the connection between neurology and urology. You see the kidneys are pictured as brains connected to the urinary bladder. What it is important, ladies and gentlemen, is that the level of the neurological lesion is in principle predicting what you would expect as neurourological symptoms and signs. It means for a suprapontine lesion, the history will give you predominantly storage symptoms. The ultrasound will show insignificant post-void residual urine, and urodynamics will detect detrusor overactivity. In a spinal lesion, it means suprasacral to infrapontine lesion. The history will have both storage and voiding symptoms. The ultrasound, usually the post-void residual urine is increased, and urodynamics will show detrusor overactivity and detrusor sphincter dyssynergia. And last but not least, the sacral or infrasacral lesion. In the history, predominantly voiding symptoms. In the ultrasound, high post-void residual, and during urodynamics, a hypercontractile or even acontractile detrusor. All the relevant issues in neurourology are summarized in the EAU guidelines under the chair of Bertil Black. Have a look into these guidelines. They are regularly updated year by year. Or you have the other possibility, look into the AUA guidelines. Here, under the guidance of David A. Ginsberg, we have the guideline on the diagnosis and evaluation, and the second part is treatment and follow-up. Both the European and the American neurourology guideline are really worth to go step by step through. Have a look into this. most of them are very, very straightforward. Obviously, there are differences, there are regional issues, and so on and so on. But be aware of the following. The situation that we have in neurourology, as I already pointed out, is protect the upper urinary tract, improve quality of life. Here the typical Mickey Mouse bladder. How we treat in general neurourological patients. First, antimuscarinics, if refractory, anabotulinum toxin A injections into the trousers, or some type of neuromodulation, here exemplified as percutaneous tibial nerve stimulation. But it could also be that the patients are still refractory, then you may consider bladder augmentation. And in some of the patients with stress urinary incontinence, an artificial urinary sphincter. And last but not least, it may be as a salvage procedure that you have to take out the bladder and to derivate, to consider a urinary diversion, here with a continent catheterizable reservoir that you can catheterize through the umbilicus. Ladies and gentlemen, we will enter now the discussion of neuromodulation. Neuromodulation, first, it is highly relevant that you understand it is not the same as neurostimulation. Neuromodulation means it is a stimulation that influences, it modulates pre-existing activity in a neural pathway. In summary, it is an indirect effect. In contrast, neurostimulation is the stimulation of efferent nerve fibers with direct effect on the target. Example, a contraction of the muscle. It's a direct effect. And in neurourology, the best example for neurostimulation is the Brindley stimulator. Here, you have the stimulator, you cut the dorsal roots, at the anterior roots you implant an electrode, and in this way, with stimulating on the anterior roots, the electrode, you will get a contraction, a direct effect of the bladder, because the bladder is contracted, and also the bowel will contract. It's also direct effect there. This is the typical way how neurostimulation works. In contrast, neuromodulation. What are the indications in neurourology? We have a refractory problem. It is important that neuromodulation is not for primarily treatment. It is refractory. Urinary urgency with or without incontinence. Chronic urinary retention. Be aware that it's a non-obstructive way. It means non-anatomical. Obviously, you could have a functional obstruction like detrusor sphincter dysynergia, but not an anatomical obstruction. Therefore, non-obstructive into brackets. And bowel dysfunction. And also, in brackets, chronic pelvic pain. In some of the patients with chronic pelvic pain, a neuromodulation approach will help, but also here, this is not a general treatment for chronic pelvic pain. In some of the patients, just it helps. In children, we have the situation that you can use transcutaneous sacral neuromodulation here with patch electrodes, and importantly, in a randomized controlled trial, you will find efficacy similar to oxybutynin. It means to an antimuscarinic treatment. A similar effect, but without having all the bothersome side effects. Be aware, however, this is not a treatment option in adults. This is for children only. What do we have? In the adult population, we have the TENS, the transcutaneous electrical nerve stimulation, with an anal electrode in both male or females, or a vaginal electrode, where you have the electrode that you place into the vagina and stimulate then from the vaginal part the pudendal nerve, or in the situation in males, ring electrodes that you place on the penis, also stimulating actually the pudendal nerve. What is the evidence here? We have to say there are randomized controlled trials, but the evidence is limited. We still need more prospective, appropriately powered and randomized controlled trial. But at least there is some evidence. As another possibility, we can stimulate the tibial nerve. Tibial nerve stimulation, either placing a needle, there you stimulate the tibial nerve. It is called the percutaneous tibial nerve stimulation, PTNS, or the transcutaneous tibial nerve stimulation, here with these patch electrodes. What is the evidence for tibial nerve stimulation? We have to say also here there are randomized control trials, but with heterogeneity, with small studies. This way also here we need more prospective data. And I can inform you, currently there is the B-tuned trial here, that trial protocol published in the BJY very recently. This is a multi-center trial with several European centers involved. This is prospectively looking into the situation whether transcutaneous tibial nerve stimulation will have an effect on neurogenic lower urinary tract dysfunction. More invasively, we would have the option of sacral neuromodulation. Here Emil Tanago. Tanago is the father of sacral neuromodulation. And I had the great opportunity once to meet Emil several years ago at the SUFU meeting in Miami. Emil is still at his old age with a great brain. It's great to discuss with him all the different issues on neuromodulation. And it is, you have to understand this, ladies and gentlemen, if you would have a date as a football fan with Lionel Messi, or obviously as a Swiss with Roger Federer. In sacral neuromodulation, you place a lead into the sacral foramen S3 or S4. It is a minimally invasive procedure. You have here the tines. With the tine, the electrode stays in place. This therefore is called the tined lead because of the tines. And with the tined leads, you will tunnel an extension cable from the gluteal side to the contralateral side, here exiting the skin on the left gluteal part. This is then connected with an external stimulator, and the external stimulator you may have one or you may have connected two, depending whether you have one or two electrodes placed. This is then unilateral or bilateral sacral neuromodulation. In the case that during a test phase of several weeks, sacral neuromodulation provides you with a positive effect, then you can implant the neurostimulator or neuromodulator, either as a one-channel device or, in the case of 2 electrodes, as a 2-channel device. Here, the radiography of a patient implanted with a 2-channel device. The situation in neuromodulation, in sacral neuromodulation, is that we have 2 companies in principle. It is Medtronic and Axonics. Both have a chargeable, and Medtronic has a non-rechargeable device also. At the moment it is in the States and in Canada, not yet in Europe, available also a non-rechargeable system by Axonics. But the problem in both, even the stimulators were getting smaller and smaller. We are still not there where we would like to be. It means nowadays, 2023, we would like to have a stimulator at this size, ladies and gentlemen. Really minimally invasive, minimal size, very, very small. This is at least my vision that we would like to have. But we are still far away from that situation. But where are we currently with sacral neuromodulation and the neurological population? We have to understand sacral neuromodulation is an accepted treatment for refractory detrusor overactivity in the non-neurological population, and also for emptying problems in the case that you don't have an anatomical obstruction, in case of chronic urinary retention, to enable the patient to void normally without an underlying neurological disease. But for the neuropaths, we looked into that in this publication more than 10 years ago. And what was the conclusion of this systematic review and meta-analysis? Ladies and gentlemen, the results for sacral neuromodulation and neurourology are promising. But there is still no RCT published on that special population at that time. And this systematic review was repeated more than 10 years after our initial publication by Arndt van Ophoven, and Arndt and his team. The conclusion was exactly the same. Promising, but at that time no single randomized controlled trial published. Nowadays, we are in the great situation that we have one single randomized controlled trial on sacral neuromodulation. Here, the protocol paper, it is an initiative of 4 centers in Switzerland, and these results have very recently been published in the New England Journal of Medicine Evidence last summer. We will go into the details just in a moment. This investigator-driven, initiated, randomized controlled trial includes 4 Swiss sacral neuromodulation referral centers. The stratification was according to the study center and to the type of the underlying neurogenic lower urinary tract dysfunction. It means urgency frequency syndrome and or urgency incontinence, chronic urinary retention, and a combination of both urgency frequency and chronic urinary retention. The primary outcome of this randomized control trial was success of sacral neuromodulation. It means improvement of at least 50% in key bladder diary variables compared to baseline. This according to the literature, defined as urgency frequency syndrome, urgency incontinence, relevant here the number of voids and number of leakages. For chronic urinary retention, the amount of post-void residual, and for the combination of both voids and leakages and or post-void residual. Secondary outcomes were bladder diarrhea variables, urodynamic outcomes, quality of life measures, and adverse events. Considering the patient characteristics, their median age was 40 years. About more than 50%, 57% were females. The dominant neurological disorders were spinal cord injury, multiple sclerosis, Parkinson's, cerebrovascular events, and cerebral palsy. We finally assessed for eligibility and tiny lid implantation 124 patients. They were all enrolled. At the end of the sacral neuromodulation test phase, there were 122 patients. We had 2 dropouts. The situation was that failure rate 57 patients compared to the success with 65 patients. The sacral neuromodulation test phase was a minimum of 3 weeks. Then we looked into the patients were successfully tested with sacral neuromodulation. 64 of these patients underwent implantation of the neuromodulation. We had 1 dropout. This patient was never implanted because it was a permanent carryover effect. It means this patient had an effect after tiny lid implantation without connecting a neuromodulator. Okay, we were very happy. This patient was not implanted and is still not implanted yet. There was an optimization phase after implantation of the neuromodulator. The length of the optimization phase was 2 months. The situation was that we had 4 dropouts here. Finally, we included and randomized 60 patients. And what did we do? In the active group, it means in the group with sacral neuromodulation on, there were 29 patients, and in the sham group, where we switched off the neuromodulator, there were 31 patients. You see here the type of neurogenic lower urinary tract dysfunction. Quite similar, the randomization worked well between the underlying type of neurogenic lower urinary tract dysfunction. We had no patient discontinued the intervention and were lost to follow-up. It means all these 29 and 31 patients were following the full study up to the end. The successful part in the active group were 20 versus 7. In the sham, it was 13 versus 18. But beware, still 13 patients were successful in the sham group. The primary outcome, thinking about statistics, was successful in a significant way. It means 76% of all the patients with active sacral neuromodulation were successful, compared to 42 with sham procedure. Be aware that the design here was very special. It means it is not so that we had no effect and then you switched on the stimulator and then you measured the effect. We started from the opposite. It means all the patients had an effect, and then you switched off the stimulator. It means we started at 100% success. With switching off the stimulator, you ended up with 40% success. With continued sacral neuromodulation, you ended up with 76%. Highly significant, the result. For the first time, ladies and gentlemen, we were able to prove that sacral neuromodulation is effective in treating selected neurological patients with lower urinary tract dysfunction. In addition, the treatment was safe. It means efficacy and safety have been shown for the first time in this RCT in selected urological patients. Now, ladies and gentlemen, neurourology. Quo vadis? Some of you may have seen this famous movie Quo Vadis. It is so that we don't need to go back to the Romans. We can go back to this other famous movie, Back to the Future. The situation is Back to the Future to the Brindley stimulator. The situation in Europe, we hardly have any patient. They undergo a Brindley procedure because you have to cut the dorsal root, do a dorsal rhizotomy. And most of our patients just refuse for a iatrogenic lesion on your nervous system. And in this way, in Central Europe at least, there's almost no Brindley procedure. You in South America, in Colombia, you have Juan Carlos Castaño. He probably is the specialist doing most on the anterior root stimulators in the world now. And it's a great way that you still keep this experience in your country. In my opinion, it's a great procedure considering the right indication. And for Europe, there may be a revival of anterior root stimulation, but only when you don't need to cut the dorsal roots. For instance, when you have, like here, a closed loop system, a closed loop neuroprosthesis. It means that instead that you cut the dorsal roots, you may, by stimulating, by electrical currency, that you can relax the detrusor muscle, that you have the same effect in the case as you would really cut the dorsal roots. The problem here is, you see the publication date, 10 years ago now, this animal study, still not yet transferred to humans. There will be still a big question mark whether it would be possible, whether it would come to daily clinical practice. I doubt, for the moment at least. The other way is deep brain stimulation. You place an electrode into different brain areas, especially in movement disorders. The typical way, for instance, in Parkinson's disease, is the nucleus subthalamicus. It could also be the nucleus ventralis intermedius in patients with essential tremor, also in patients with dystonia, or in patients with Parkinson's disease, it could be the globus pallidus internus. There are different areas, different locations where you can place the electrodes, and some of this have really not only an effect of the motor part, but also on the autonomic nervous system. But obviously you would never go just for deep brain stimulation to have an effect for bladder function. But you can advise the neurosurgeons, in general, it will not be worse, a neurogenic lower urinary tract dysfunction, but in general it would improve. And this is already a lot of your colleagues. Another situation, early sacral neuromodulation, published many years ago by Carl Dietrich Siewert and the Tübingen team. What did they do? They implanted a sacral neuromodulation system in patients after complete spinal cord injury, and they realized that in the patients implanted with the neuromodulation system compared to the control without implantation, they could prevent urinary incontinence. See here in the urodynamic exam on the left side with sacral neuromodulation, no detrusor overactivity, and on the right side you see clearly the overactive bladder, even with pressures jeopardizing the upper urinary tract. In the case that you could prevent with a neuromodulation technique that you would develop a pressure in your bladder with detrusor overactivity that is jeopardizing your upper urinary tract, this would completely revolutionize the field in neurourology. We tried to convince our patient to go for a similar study in a randomized way, but we realized it is not possible in Switzerland when you would implant at this early stage after spinal cord injury this special population. Therefore, we are designed a completely different way. We are currently looking into transcutaneous tibial nerve stimulation in patients with acute spinal cord injury, with the idea that in a window of opportunity within the first 40 days, when you start then with tibial nerve stimulation, it means, as a hypothesis, there is still some plasticity where you stimulate the tibial nerve, then you could prevent neurogenic detrusor overactivity. This is a sham controlled nationwide randomized double-blind clinical trial. We have now about included half of the patients. The population size is a bit more than 100 patients that we would like to have. It means a bit more than 50 patients per arm. In this way, we are very much looking forward. I don't know yet the results because I'm still blinded. The patients are also blinded. Only the operators providing the stimulation, they know whether the patient is stimulated, yes or no. This is a great opportunity. We will looking forward to the Tusky trial, and in several years at least, I hope that I can give you some important insights. Another possibility, this is really still future. It is optogenetic neuromodulation. You could switch on and off nerve fibers with optogenetics. The problem is that also this is not yet real. This is on a preclinical part in animals where optogenetics is used currently. There's no single trial on that situation here. Obviously, if this would be possible, this would be not only a revolution, this would be a super revolution, ladies and gentlemen. And finally, you see, per aspera ad astra. It means to the stars. This is where neurourology needs to go to improve quality of life and to save the upper urinary tract. Nevertheless, ladies and gentlemen, there remain many questions. Questions upon questions. However, there is light at the end of the tunnel, ladies and gentlemen. At the end of the tunnel, there is a society called INUS, the International Neurourology Society, welcoming anyone involved in neurourology. This society will help you to treat these difficult cases, will fully support you in difficult questions. Become an INUS member. Thank you. Ladies and gentlemen, Julian then asked me that I should answer some questions. He was especially wondering whether neuromodulation is a valuable treatment option for neurological patients. What about patients with spinal cord injury, and what about a high pressure bladder system? I have to say the situation at the moment, as I explained to you, it is one single RCT. This is the RCT published last year in the New England Journal of Medicine Evidence. It is in selected patients only where sacral neuromodulation helps. We don't know yet exactly which are the best type of patients, but what it is very clear, when you have a patient with a spinal cord injury, you have to look how complete this injury is and how your patient is regarding the comorbidities. The situation at the moment is, I would advise you to go for sacral neuromodulation in a try and error model, but bring your patients in a study protocol, because then we can learn what sacral neuromodulation is really doing in this special subgroup of patients. Also, a high pressure bladder system may be an option, but most importantly, you have to undergo urodynamic evaluation before and during sacral neuromodulation. It means it doesn't help your patient really if the patient is not incontinent but still has a reflux and jeopardizes the upper urinary tract under sacral neuromodulation. Therefore, pre and during sacral neuromodulation, go for urodynamics, for video urodynamics, and in the case that also the upper urinary tract is safe, then obviously you can implant such a patient. Other questions were the mechanism of action of sacral neuromodulation. Is it an effect on the detrusor and or the external sphincter? The other way round is detrusor acontractility. It means without any contraction of the detrusor, a contraindication for sacral neuromodulation. We have to be honest, and the mechanism of action of neuromodulation is not completely clear. Nevertheless, there are excellent models that shows that effect is go through the afferent nervous system. It means the afferent fibers are going up through the spinal cord. There are some relay station in the spinal cord, but also in the periaqueductal gray area, and there with MRI and PET studies it has been shown that there are several changes. It means there is an effect on the detrusor muscle. Detrusor overactivity can be improved, but it is also an effect on detrusor sphincter dysynergia. It means also in patients with detrusor sphincter dysynergia, sacral neuromodulation may have an effect. Now, the question is whether acontractility is a contraindication. No, it is no contraindication. There are only the situation that you try and in some of the patient you really still have an effect with sacral neuromodulation. What may be the mechanism of action? It could be that it's just a contraction of the external sphincteric muscle is inhibiting the detrusor contracting in such a way that when you neuromodulate, this inhibition is relieved. But it could also be that just because of an overactive sphincter that you are targeting with sacral neuromodulation, and if you can treat such a patient, then the patient can empty the bladder. Also here, try and error, but in patients with an underlying neurological disease, I would strongly advise go for a study protocol. And last but not least, percutaneous tibial nerve stimulation or transcutaneous electrical nerve stimulation, are they predictive factors for sacral neuromodulation? It means in the case of positive PTNS, positive TENS, could you go for implantation of a full neuromodulation system without any test phase? I would not go without any test phase, but what is very clear, when this neuromodulation approaches do already have an effect, then I would expect that also sacral neuromodulation has an effect, and even a better effect, because you're closer to the nerve, it is more invasive, it is more sophisticated. In the situation that there remains still other questions, please send me an email. I will try to answer your question. Julian will provide you with my email address, and once again, I'm looking forward to welcome you as an INOS member, and maybe some of you to meet in person, hopefully within the next years, somewhere in Colombia or in Europe, especially in Switzerland. Thank you so much. Have a nice evening. Bye-bye.